Hello and welcome to IITV. I am your host, Justin Longo, and with me in the studio is Healthcare Policy Center Director, Linda Gorman. And so today we're going to talk about Linda's brand new gig on the Healthcare Commission. So now, as a Politico in Colorado, I am very familiar with blue ribbon commissions. Is this Healthcare Commission like a blue ribbon commission where it seems to be kind of window dressing on something, or what is your take on this commission? Tell us a little bit about it.
I think it could be window dressing, but I'd rather that it not be, and I think most of the people on the commission hope that it isn't. Done properly, it's going to be a real chance to look at some of the important drivers of healthcare costs in Colorado. And from my perspective, one of the most important ones there that the state can do anything about is regulation. Both how it regulates and licenses providers, how it reduces competition among hospital and alternative type health care arrangements, its slavish devotion to Obamacare, in which it said, well, we're going to ban any insurance policy that doesn't copy the Obamacare insurance mandate. So there's a lot of things that we can do, and since we've only had one meeting, everybody hopes that they can still be done.
What's the origin of the commission? How did this all come about?
It came from Senate Bill 187 in the 2014 legislative session, and it's simply a statute. The commission has $400,000 of taxpayer money to spend, which ups the stakes for spending it wisely. I think it would be a big mistake to reinvent the wheel, waste a bunch of taxpayer money looking at things like, well, how much have we been spending in the past? Well, we know how much we've been spending in the past. We really don't need to look at that. And if you want to cut costs, you have to look at alternative ways to do things, not just simply saying, well, we spent too much on delivering babies in Medicaid, so let's deliver fewer, or something like that. That's what one of the Medicaid reports said for Colorado, that a major cost driver was delivering babies.
So stop having babies.
There was this tremendous question from the Joint Budget Committee analyst, and he just kind of very quietly said, well, yes, but how are you going to control that cost driver? So the thing you have to remember about healthcare is that it always costs more to treat people than it does to let them die. And so you always have to be very careful when government, comes in on its elephantine feet and says, I'm going to fix things. Yeah, usually it's by not treating people.
So we've got this commission that was born out of a legislative directive, bipartisan, I'm sure, right?
Yes.
Bipartisan,
yes.
187,
yes.
Senate Bill 187. And the stated goal of the commission is to figure out what is driving costs in healthcare in Colorado and try to reduce these costs. That's the stated goal of the commission?
Sort of, yes. But then there's some language in there that makes you think you should be very careful, because it also says that we should control state expenditures, all the while, of course, ensuring quality health care. And I think the thing that most people don't understand is that costs and expenditures are two different things.
How so?
Because a lot of things, especially in healthcare, aren't properly priced. It would be the example, you go to get concert tickets, but you have to wait in line for 2 days to get the concert tickets. Well, part of the cost is the amount you spent for the actual ticket, and part of the cost is missed wages, or if you were just having to sleep on the ground or whatever to wait in line. And healthcare is the same way. It may be that you pay very little for a doctor visit, but if you have to wait 8 months for that doctor visit, or you have to drive 2 hours for it, or if you have to sit around in a clinic waiting all day long for a single appointment, there's a very high cost there. And one of the problems we have in healthcare is that for much of what we call healthcare, especially the government and the insurance systems, things are not properly priced. Medicare runs thousands and thousands and thousands of administered prices. They're these equivalent of price controls. And everybody copies them. And so that distorts the signals that go from people who want healthcare and people who supply it. And that's part of the reason we have such a mess. So if the commission just goes and says, I want to control expenditures, without understanding that the expenditures don't tell you how much something costs, then we'll have a real problem.
You know what it sounds like you're describing, and as a fellow economics nerd myself, I went to George Mason, studied econ.
Yes.
It sounds like you're describing opportunity cost, what you had to give up in order to get it. So that in an economist world, in our nerdy worldview, yes, it is nerdy, we see costs as the opportunity cost. And so like in your example, you're waiting 2 days to get concert tickets. It's not just the cost of the tickets, it's everything you gave up to wait in line and everything you gave up to buy those tickets. So do you think that the commission will hear and you're the appointed healthcare economist, right? Is there another economist on this in this commission?
They put a health economist slot in there, and I'm the health economist.
Okay, you are the health economist.
And when they said, stand up and introduce yourself, everybody, and tell what constituency you represent, I'm scratching my head going,
economists?
So I stood up and said I represent the constituency of ideas, where we know some things work and that other things don't. Everybody else was representing the poor or the providers or the hospitals or something. So it should be an interesting discussion over the next few years.
Maybe you can convince them that the way to look at cost is opportunity cost. And maybe you can convince them that expenditures and costs are two different things.
One hopes. And that the price system is very important, since we're being economics nerds, and the price system is really how everybody communicates. Mm-hmm. There was this really interesting study in Europe, and Europe is pertinent to this because everybody says, the European systems, they spend so much less than in the U.S. Well, the Europeans are very conscious of the fact that their systems have administered prices, and so they don't see how much something costs, because lots of times the costs get buried in government budgets, it gets buried in waiting lists, it gets buried in the fact that they have higher mortality rates for a lot of things. And so the price somebody pays for healthcare really there means nothing. Mm-hmm. So a group of researchers went out and decided, okay, we're going to take a resources approach, and we're going to look at the cost of something really basic. And they picked filling an uncomplicated cavity, dental cavity, in a bunch of countries. And they went and they tried to look at the dentist's costs, the office costs and everything, and then they tried to price them as the countries price things. And they found that the cost varied by 400%. And that's a sign that markets are not functioning very well, because you would expect it to equalize. And it's also a sign that prices and expenditures are two different things, and you can't look at how much they say they spend for healthcare in the UK and say anything about comparative costs with the US.
Another way to look at it would be the cost of something is not simply the dollars and cents that you see reported from a government or what have you. It's more than that.
Sure it is. I mean, if I have to, if the only way I can get health care is to go and sit in a clinic for 6 hours, that's very, very costly. Mm-hmm. Or
wait for 2 weeks or 4 weeks to see somebody or get some sort of procedure. I mean, these weeks-long waiting lists are real.
They're real, and they kill people. The Swedes for a long time have been trying to manage their cardiac waiting lists, and they find that the longer that being on a waiting list is associated with about 11% higher mortality. And they have tried for years, and there's nothing you can do. You need for some things you need immediate medical care just to get on with your life. So there's nothing wrong with saying let's have immediate medical care, which is one of the reasons a private emergency room opened here in Arvada. It's in a suburb of Denver. And they opened there because in all the surrounding hospitals, the waiting lists were fairly high. That area didn't have good access to hospital-based emergency rooms, so a group of docs opened their own. The people in the neighborhood like it. The state tried to shut it down. And one of the people who wanted to shut it down simply said, well, you can wait a little bit longer for your care. To which one of the women who went to the town hall meeting went, yeah, well, you wait till your kid is turning blue and tell me that I can wait a few more minutes. I'd already waited an hour and a half at another ER. My kid couldn't breathe. I'm going here. How dare you shut it down? If people don't want to go there and they can't make enough money to stay open, they'll shut down automatically. So there's a lot of things we can do in healthcare that'll really improve things. But you got to give power to the people, and you've got to get rid of this everybody's got to get care in the same way notion, and you've got to let the suppliers, you've got to free the suppliers to compete and charge reasonable prices. And you can still subsidize people that way.
Right.
Because you can give them money. I mean, it's
absolutely.
It's not hard to subsidize people.
You've had one meeting with this group already.
We organized.
There's a bunch more meetings coming up,
yes.
I'm sure. How long are you in this commission?
Years.
It could be years?
I think it's 3 years.
Wow.
I could be wrong. I tried not to look, yeah.
Okay. So for a few years, you're going to be meeting with this commission. What is the end result of all of these meetings over a few years? Like a paper, a white paper or something? A report.
A report. And
Okay.
the report is supposed to recommend things that state government can do to bring down healthcare costs, provide affordable healthcare for people, and reduce state expenditures, deploy state expenditures to things that will be best for the health of Coloradans.
All right. Well,
And everything has to be evidence-based.
that sounds good.
It does sound good. The problem is that sometimes economists look at evidence differently than other disciplines. So that'll be an interesting conversation, too.
Oh, I know. All right. Well, Linda Gorman, we appreciate you being on IITV. Folks, check back to our YouTube channel to catch the latest from the Independence Institute. Thank you for watching.